goals of pediatric tracheostomy care are to maintain a patent airway at all times, to remove debris from the incision site to keep it clean and facilitate healing, to help prevent complications, and to prevent accidental dislodgement of the tube. Pediatric tracheostomy care also strives to maintain, as normal as possible, the growth and development of the child. The clinical priorities for pediatric tracheostomy care are wound care, airway care, securing the airway, management of secretions, and humidification of warm mist to maintain ciliary function. Additionally, your priorities are maintaining an open airway, preventing complications, and having appropriate equipment at the bedside. It is also important to note that a significant humidity deficit can result in pathologic changes in the structure and function of the airway. Maintaining proper humidification will prevent long-term damage to these structures, which may impact the child's respiratory function after decannulation. Because of the narrow tracheal anatomy of younger children, tracheostomy tubes for these patients are limited to the single cannula design option. As a result, tracheostomy care in children requires additional diligence in the prevention and removal of secretion buildup inside the tube so that the artificial airway can be kept patent. External and internal humidification can help to reduce the viscosity of secretions. To keep the inner cannula of the tube clear, suction the tube as needed. Generally, use the largest diameter suction catheter that is still narrow enough to advance within the inner lumen and advance it just past the distal tip of the tracheostomy tube. Children with tracheostomies should be taught to cough and deep breathe. Coughing can mobilize secretions, so a cough is really the best suction. Immediate postoperative care of the pediatric patient with a tracheostomy includes several elements. A chest x-ray to evaluate correct placement of the tube and to evaluate possible pneumothorax, securing and cleaning sutures and ties, suctioning of any expected postoperative bleeding from the incision site and normal secretions, appropriate pain management, elevating the head of bed if tolerated to improve ventilation, prevention of accidental decannulation of the tracheostomy. It is important to proactively ensure the integrity of the inner lumen of the airway to maintain airflow and thereby minimize work of breathing. There are several possible intraoperative and early post-op complications related to pediatric tracheotomies. Because the surgeon performing the tracheotomy is working with a tiny airway and within a small anatomical area, a posterior tracheal wall tear is a possibility during the surgical procedure. In addition, there are many other potential complications, which may include respiratory arrest, tube or ventilation problems, accidental decannulation, blockage of the tube by normal secretions or bleeding associated with any surgical incision, tracheoesophageal fistula, granuloma formation, suprastomal collapse, pneumothorax, and tracheal stenosis. Late complications of a pediatric tracheotomy can add to the long-term challenges for the patient. These include stomal granulation or granulation tissue growing around the stoma, stomal infection, hemorrhage, tube obstruction by dried secretions, and scarring associated with the closed stoma. When should the tracheostomy tube be changed? It is common practice to wait to change the first tube until postoperative day 5 to 7. At this point, the track should be established. Many experts recommend weekly routine tube changes for neonatal and pediatric patients. Pediatric and neonatal tubes are commonly coated with a thick layer of adherent mucus and biofilm, even with proper humidification. At home, tracheostomy tubes are typically changed once a week. The frequency of tube changes is determined by the mucus buildup inside the tube. It is important for families to practice routine changes so that when an emergency does occur, the change is not difficult. Inspect the inside and outside of the tube that has been removed for dried or thick mucus. If mucus is built up, you will need to change the tubes more frequently. It may also be necessary to use additional mist, humidification, and fluids. Being prepared for all emergencies is a part of standard care for all tracheostomy patients. The tube should be changed immediately if you are unable to pass the suction catheter through the tracheostomy tube, or if you are unable to feel or hear breathing through the tube and the child is becoming pale or blue and suctioning does not change the picture of distress. The tube should also be changed if the child has any increased respiratory distress and the chest wall is pulled in with no relief after suctioning. To ensure emergency preparedness, it is important to have the correct supplies at the bedside. You should keep 2 extra tubes at the bedside, one that is the same size as the current tube and another that is the next available size smaller in the event that you have trouble inserting the same size through the stoma site. A pediatric and neonatal post-tracheostomy tray and suction catheters should also be kept at the bedside in case of an emergency. Functioning suction equipment must also be available. Call the physician if you are unable to pass a suction catheter through the tracheostomy tube, if the flange or faceplate will not remain flush with the neck, or if there is any respiratory distress that is not resolved by routine proactive tracheostomy care. There are several alerts that should trigger a consultation with a physician, your mentors, or expert nurses. These include purulent secretions, a pressure sore from the flange or faceplate, and formation of any granulation tissue at the stoma site. Other examples include soiled dressings that you can't keep clean or an unusual odor from the tracheostomy tube. These may indicate an underlying issue that needs to be addressed. As frequently as necessary, use a cotton-tipped applicator with a cleaning solution to remove secretions and debris from the wound site behind the flange or faceplate. Let's review evidence-based practice for suctioning, humidification, and saline installation. When patients are able to do so, teach them to cough, deep breathe, and clear their own secretions. Address the patient's requirements for humidification. Counteract the effects of insensible water loss by monitoring water balance. Saline installation is controversial but may be appropriate for selected patients. Consider using saline with spontaneously breathing patients, but only as necessary to clear secretions. Communication and voicing is a very important topic in pediatric tracheostomy care. The placement of a trach tube in the upper airway may adversely influence speech acquisition in infants and children since the tube bypasses the larynx. When safe, always allow for an air leak around the trach tube. Provide enough forced air for speech through the normal glottis and never allow the tube to place pressure on the native trachea. The outer diameter of the tube is not to exceed 2/3 of the tracheal diameter when using a speaking valve. Select patients very carefully for finger occlusion, for capping, and for use of speaking valves. Provide an evaluation by an experienced pediatric speech pathologist and provide speech therapy. Alternative methods of communication, such as electronic keyboards, can help the child learn and communicate. Family education is essential for ensuring their competence in tracheostomy care and to facilitate a safe transition home. Caregivers must know how to change the tube and how to manage the ventilator equipment. A 24-hour room-in period at the hospital to demonstrate all necessary care under supervision helps build the family's confidence in making the transition from hospital to home. Discharge planning plays a vital role in improving patient care and managing healthcare system costs. For neonates or children who require lengthy hospitalization from birth, shortening the hospital stay can decrease the risk of hospital-acquired morbidity, shorten the period of separation of the parents, and lower medical costs. The determination of readiness for decannulation is done by fiber optic endoscopic evaluation or speech and swallowing, also known as FEES. The child's trach would be downsized to enable enhanced breathing around the outside of the tube. A decannulation test would also be performed to determine if the child can breathe without the tube. Let's recap some takeaways for pediatric tracheostomy care. Remember to use every opportunity for patient and family teaching, including during routine trach care and trach tube changes. Proactively ensure the integrity of the inner cannula of the airway. Always keep in mind that prevention and understanding of early and late complications are clinical priorities.